Welcome to Your Case is on Hold, a JBJS podcast hosted by Antonia and Andrew Schoenfeld.
Here, we discuss the science in each issue of JBJS with an additional dose of entertainment and pop culture.
Take us with you in the gym, on the commute, or most certainly, whenever your case is on hold. Welcome back, everyone, to Your Case is on Hold, episode 83. If you're listening for the day that we release, it's June 3rd for June 4th issue of JBJS. We are covering the best, brightest, greatest, and latest in orthopedic research as published in the Journal of Bone and Joint Surgery. I am Andrew Schoenfeld, Deputy Editor for Methods, Market 8 dude.
And I'm and Deputy Editor of Adult Reconstruction, not a Market 8 girl.
But you're like, you got a promotion. You're not really the Deputy Editor anymore. You're something else, right?
Oh my gosh, you're right. I am Executive Editor. But I'm something different.
That sounds fancier.
It goes from D to E. I don't know if that's good or bad. I mean, in great system,
then you're going down.
So we'll see.
E is for excellent. Anyway, this episode of JBJS is brought to you by the JBJS family of publications. Get everything you need. Get your research published in the venue that works right for you and your work. JBJS, JBJS Open Access, JBJS for Physician Assistants, Case Connector, Essential Surgical Techniques, JBJS Reviews, the CME, Clinical Classroom. It's 360 wraparound services at jbjs.org. If you're not familiar with some of the things I mentioned and you need to check it out, go to www.jbjs.org. It's one-stop shopping, and you can get everything you need there, including the image library, including the JBJS Buzz content, including information about getting JBJS CME, really everything you need at the fingertips at the one-stop jbjs.org hub. As always, what we're covering here are our opinions and ours alone, and not those of the board of directors, the board of trustees, the other editorial board members, some with new titles, the other editors of the journals in the JBJS family of publications. Some of the takes, especially on this one, I'm not sure they're hot. They may cause some controversy, but we'll get to that. Let's cover what's at the top of the pile first. We have AOA Critical Issue Symposium, Current Opinion in Orthopedics, Orthopedic Physician Leadership in the Evolving Academic Healthcare System by Black. Then Trends and Retraction of Orthopedic Research Articles by Gerges and colleagues. What's Important? The Green Whistle by Lee, that's permanently free. Delamination and Oxidation in Compression Molded Polyethylene by Nickel. Then we have Metaphyseal Fixation in Newtonian Arthroplasty by Megaloeconomos and colleagues. Role of the CT scan in preoperative planning for Tillot-Chaput fractures in adults by Masari Pugin and colleagues. Increased prevalence of scoliosis in female professional ballet performers by Lambert and colleagues with a visual summary and permanently free. Experimentally induced femoroacetabular impingement results in hip osteoarthritis, a novel platform to study mechanisms of hip disease by Kaminaga and colleagues. Mutilization at the site of varus derotational osteotomy of the proximal femur may reduce instability recurrence in cerebral palsy by Valim and colleagues. And then monitoring sleep breathing disorders in patients with idiopathic scoliosis by Feng and colleagues. And that brings us to the headlines, what's new and exciting in the orthopedic news this week. My headline is Risk Factors for and Prediction of Early Thromboembolic Disease Following Adult Spinal Deformity Surgery, an analysis of over 7,400 patients with spinal deformity by Gallagher and colleagues, permanently free. Now, when the articles came out for this issue for us to select, my agent called me up And he said, Shoni, because that's what my agent calls me. He was like, Shoni, do not pick this Gallagher article for your headline. Don't touch the Gallagher article. Pick something else. But I'm my own worst enemy. So naturally,
Were you one of those kids that say, don't touch this, and then you touched it?
no, I don't think so.
Okay. It's like when someone says, oh, this smells so bad, and then puts it in front of your face, and you have no choice but to smell it. So now you got to do it.
Yeah. No, it's not that. It's like after thinking about it and going back and forth, I understand why my agent was like, no, don't do this one. But at the same time, I think that there's a lot that we can share with the audience that we can all learn together from this particular paper. So I think there's value in discussing it and presenting my impressions of it. And may lead to some controversy. I'm not sure, but some controversy is good. And if it helps, people grow and evolve and develop their own understanding of the literature and research better, I think that's to everyone's advantage. I don't see a downside to that. So let's get into it. This study is a study using the National Surgical Quality Improvement Program data set. They used the years 2010 to 2019. Now, the NSQIP or NSQIP, or some people call it NSQIP, I think most people have at least some passing familiarity with it or have seen literature that's been produced using it. It's really been used in the orthopedic literature since about 2010, 2011. I've done studies using NSQIP. That's how I refer to it for full disclosure. I believe you've done NSQIP studies. So it isn't necessarily anything against NSQIP per se, but I mean, it's important to understand a few things about NSQIP. The intent is it's a quality improvement program. It's voluntary to participate. The centers that participate and contribute to NSQIP are overwhelmingly tertiary or academic facilities. Now, they do have some nice features. It does capture some lab data. They do have nurse abstractors. So there's greater fidelity, and they have process improvement measures, and they review and audit cases that they're abstracting. But the intent is quality improvement. It's not research. Depending on like which format of NSQIP the contributing institution is subscribed to, there are going to be different amounts or different numbers of cases that they're contributing, different types of cases. And it used to be that NSQIP was just really limited to the United States and then North America, but now I believe that there are some international contributors. And I'm not clear about if that gets into what's called the participant user files or not. And since they're using somewhat older data, I'm not sure that's an issue anyhow. The fact that they are using somewhat older data, I think, is an issue in and of itself. Obviously, here we are, and their latest data that they've collected is 2019. Now, some might say, well, but that's going to give you long-term follow-up. But that's the real issue with NSQIP, is that they only follow patients for 30 days, as long as they've been discharged in situations which are obviously going to be few and far between, where they're staying in an inpatient facility or something to that effect. Then they will continue. But once they're discharged, they basically follow them for 30 days from the date of the intervention, is my understanding. And then that surveillance stops. And the authors are upfront about that. They make an interesting comment that we'll talk about. So, this is essentially kind of revisiting sort of the classic type of study that really used or leveraged NSQIP as a substrate in years past. It's what we would call a risk factor for outcome X in procedure Y or condition Z, or both. In this case, it's risk factors for venous thromboembolic disease following adult spinal deformity surgery. And the study obviously is limited to 30-day follow-up. The authors are transparent about that. Now, what they say is, and this is, their strategy to insulate themselves against reviewer critique during the peer review process, or possibly any critique, although I don't think it holds up very well. They say that the 30-day follow-up period is adequate for identifying postoperative VTEs and those occurring greater than 30 days postoperatively are unlikely to be attributable to surgery. Now, I think that statement doesn't hold up in the context of the way insurance and CMS look at global outcomes. And also, how do you know? Like, you don't have the counterfactual for the patient to say, like, this VTE that occurred, this DVT at 29 days, that was post surgical. This one that was at day 32, that wasn't. Nope, that's about something else. Patients are a composite. It's the holistic person, and if they have risk factors that predispose to the development of complications, be they surgical site infections, cardiac complications, the longer your time window, the better it is. Now, you can say certain complications after a point are probably less likely than not, but that's all you can say. So at 2 years out, maybe, yeah, it's less likely than not. You still can't say it's definitely not. So such a definitive statement to say anything beyond 30 days, that's not even going to be attributable to the surgery. When you're talking about a major surgical intervention that puts patients down for an extended period of time, high levels of intensity, long-term recovery, I just don't think that that statement really has good face validity. And I would maintain that they're missing very many VTED events after the fact. So then the NISQIP relies on CPT codes. They are using two codes that are basically based off of the number of levels fused, which certainly makes sense. It's probably very sensitive for ASD surgery, but it's not very specific. And they didn't describe the surgeries further. I mean, they could have looked for other codes to say what had a decompression or not. Maybe it's going to be very difficult to parse out exactly what types of surgical procedures these were beyond just saying yes, they received these instrumented fusions. And then they go into a logistic regression analysis with forward entry. If you're going to do something like this, it's probably better to have a conceptual model than to just be letting the essentially the statistical analytic approach inform how your findings are gonna work out. And that just creates the potential for real artifacts to be present in the model. Things are not that useful or not that informative or are present just due to chance showing up as being influential or informative. And then they say to further test the model, 20% of cases were not selected for the initial model, but were matched to three separate randomly selected test groups of patients from the population without VTE to confirm whether the model yielded statistically similar AUC metrics. So they're really evaluating the discrimination capacity. This is it's another test, but I don't think it's a very robust test because there is such a thing as like the NISQIP phenotype of patient. So again, keep in mind these are high intensity interventions that are performed at tertiary, overwhelming academic medical facilities. So when you're cutting the sample and you're just saying arbitrarily we're just going to like leave 20% out, that 20% is probably not that different from the 80% that you already have, given that it's NISQIP data. So this is not a reassurance. It doesn't provide any further evidence or proof or value than if they had not done that approach, in my estimation. So some further points here. They are transparent on the final model. They said had fair discrimination with AUC of 0.71. That's just at the borderline. 0.70 would be the cutoff for what people call fair. So it's lower there. And that means that there's about 29% of the variation in the development of this VTE complication as they're modeling it is not explained by the factors that they have. That's a fairly high degree of residual confounding. So ultimately, they identified factors associated with the risk of any VTE, and it essentially comes down to chronic corticosteroid use. I'm sorry, longer length of stay, longer operative time, chronic corticosteroid use, higher ASA, higher BMI, hypertension, older age, and bleeding disorders. So my first question is really, what did this tell us that we didn't already know about VTE risk? I mean, all of those factors are factors that if like you just looked up I'd wager, I haven't looked at it recently, but I'd wager if you go to first aid for USMLE step 1 or step 2 and are just like, what are the risk factors for VTE after surgery, whatever agnostic to the actual procedure, those are probably going to be there in some way, shape, or form, right? And then we already know this. There have been plenty of studies on VTE risk in non-ASD spine surgery. So how is this different from the overall composite risk for spine surgical interventions or spine fusion procedures? And then, some of these factors, such as the corticosteroid use, people are not on chronic corticosteroids just because their provider feels like putting them on it. This is a modulator. This is a signal. It's not the chronic corticosteroid itself. It's probably the underlying factor about why they're on the chronic corticosteroids, in addition to, in some cases, the chronic corticosteroids. So they say corticosteroids increase the level of procoagulant factors and decrease thrombolytic plasminogen, resulting in a hypercoagulable state. But then what about the conditions that are treated with the steroids? Might not some of those be drivers? Maybe in some cases they can't define that. Again, NSQIP isn't perfect, and it's basically taking a longitudinal record and compressing it to just sort of it's taking a 3-dimensional medical record, particularly about events before the procedure, and it's just compressing it to essentially a 30-day time window. So, I mean, at the end of the day, I'm probably left with more questions than I have answers for this particular paper. And most importantly, it's, what did this tell us that we didn't already know? How do you apply this to patient care in the context, or how does it change patient care in the context of this is 30-day data from NSQIP, for which the model has some real concerns for artifacts. Some of the variables that are considered informative are not fully explained, like corticosteroid use. And overall, based on our previous understanding about VTE after surgery writ large, or VTE after orthopedic surgery, or VTE after spine surgery, I don't see anything here that is fundamentally changing our understanding of it.
Pretty tough. Sounds like my senior thesis from college. I ended up with more questions than I answered. Sounds just about right. I'm glad you took that one on then. I think that actually was a good one.
I'm getting caught, like my agent is probably going to call me in a few minutes. Well, I guess my agent won't really know until after this drops, right?
I need a new name for my agent. I'm just Antonia. It's pretty boring. Aunt Tony is a new one that came out, though. I'll just say that.
Tony?
Aunt Tony.
Oh, Aunt Tony.
Aunt Tony. Aunt Tony. Aunt Tony. Exactly.
Is that your actual niece or nephew that's calling you that, then?
No, actually, it's not. It's my.
No. Okay.
Got it.
All right. Well, that's it. Yeah, there's some potential there. Well, let's talk Aunt Tony's headline then. Predicting post-fracture recovery with smartphone mobility data, a proof of concept study by Shear and colleagues, with a comment, and it's 30 days free.
So, as we incorporate more and more technology in our orthopedic practices, this is a study done from the University of Maryland that looked at ways to predict post-fracture recovery using smartphone mobility data. Since patients want to regain mobility after injury, especially after fractures, the purpose of the study was to use predictive algorithms incorporating pre-injury mobility data, demographic and injury data to predict post-fracture mobility. And this could be potentially a helpful tool for patients. Now, this is truly a proof of concept study, since it didn't have a lot of patients in it. It was a retrospective cohort study at a single academic trauma center, and they enrolled patients from January 2024 to May 2024. So again, a short time frame. Now, they only focused on lower extremity fractures, not upper extremity fractures. And they needed to have clinical follow-up greater than or equal to 6 months after the injury. Additionally, the patients had to have Apple iPhones. Other phone systems were all excluded, and they had to have the Apple Health app for greater than 1 year before recruitment. And the Apple Health app, just for information, was started back in 2014. So there's been plenty of time that people have had this on their phone, just because it would be collecting background data, because patients were enrolled 6 months after their injury. So it wasn't that they were enrolled at the time of injury, they were enrolled 6 months after the injury. So they had to have this data on their phone already to look back and gather this data. These Apple iPhones actually capture data that I didn't know it actually fully captured. It captures mobility metrics, including step count, which I knew, walking speed, how quickly the patient walks on flat ground, modeled according to the patient's center of mass, step length, the distance between alternating steps during the gait cycle, and is derived from the patient's height, step cadence, and speed estimation, and walking asymmetry, the time during which asymmetric steps are detected while walking, presented as a percentage of walking time, and double support time, percentage of the patient's gait cycle on both feet, ranging from 0% when running, so both of the feet are in the air, versus 100% when they're shuffling, when both feet are on the ground. The stats that the authors did, they parameterized the outcomes on a weekly basis. So for the step count, the weekly sum was divided by 7 for a daily average, and they extracted the 90th percentile walking speed and step length for the model. Double time support and walking asymmetry were modeled as a weekly average, and they calculated pre-injury means and standard deviation for each mobility parameter using data from the 6 months before injury to account for seasonal variation in mobility patterns. The postoperative step count was estimated using a generalized additive model, and all models were adjusted for age, sex, open fracture, BMI, fracture location, and outcome-specific pre-injury mobility variance with continuous covariates fitting using polynomial splines. So what did the results show? So they had 139 patients who met the eligibility criteria and were approached for consent. 11 decided they didn't want to participate, and 21 were excluded because they didn't have enough pre and post mobility data. So there's a total of 107 adult patients in this group, 45 male, 45 years old, 43% female, and then 62% white. So the step count, looking specifically at that, after injury, the average daily step count increased by 65 steps week over week. I feel like this could be a Kaiser says so say testable question about how much does your step count increase on a week by week basis after lower extremity trauma. Weekly gains were significantly greater within 6 weeks after surgery, as compared to 20 to 26 weeks after surgery. And not surprisingly, greater pre-injury steps were associated with increased post-injury steps, like range of motion. And post-injury daily step count decreased by 10 steps per 1 year increase in age. And bilateral injuries were associated with 879 fewer steps per day, 26 weeks after injury. For walking speed, they found an average decline in walking speed of 0.2 meters per second from injury to 8 weeks post-surgery. I don't know how detectable that is on a daily basis, but obviously that can add up. From 12 to 26 weeks post-injury, they estimated a 0.07 increase in walking speed. And then again, post-injury walking speed was predicted by pre-injury walking speed. And if you have 0.1 millisecond faster pre-injury speed, then you get 0.06 meters per second increase in post-injury speed. And post-injury walking speed was 0.022 meters per second slower every time you increase 10 years in age. That said, post-injury walking speed did not significantly differ in patients with bilateral compared to unilateral injuries. And for walking asymmetry, the average walking asymmetry worsened by 25% from injury to 8 weeks post-injury, but then improved by almost 6% from 12 to 26 weeks post-injury. And it varied from pre-injury asymmetry with a 5% increase in pre-injury asymmetry associated with an almost 4% increase in post-injury asymmetry. And that every 10-year increase in age was associated with almost a 3% increase in post-injury asymmetry, and no significant differences in bilateral versus unilateral. Step length. So initially in the first 8 weeks, it declined by an average of 0.04 meters and then increased by 0.03 meters from 12 to 26 weeks. So just everything. It dips down, comes back up. In this case, pre-injury step length did not predict post-injury step length. And bilateral injuries were associated with the reduction in step length. And finally, average double support time increased by 1.5% in the first 8 weeks and then started declining after 8 weeks by 0.4% in 12 to 26 weeks. and 1% higher pre-injury double support time was increased with an increased post-injury double support time. If you were more likely to shuffle before surgery, you're more likely to shuffle after surgery. Every 10-year increase in age predicted a 0.2% increase in double support time, and it was similar between bilateral and unilateral injuries within 8 weeks after injury, but it was higher, or the double support time was higher with bilateral injuries, which is not surprising, especially if lower weight bearing. A visual comparison of observed versus predicted values suggests that the models were well calibrated, again, throughout all the different models here. And the conclusion in this proof of concept study found that pre-injury mobility data can help predict recovery after fractures. This is a small study. It is a proof of concept study. It would have been nice to follow this up out to 1 year instead of just 6 months to see if that does change over time. It also would have been probably nice to follow patients prospectively instead of just querying their phone afterwards. So if they, got it at the time of the injury prior to recovery to capture more data in the postoperative period. Now, this didn't have recall bias, but you never know if the patient's always wearing the phone or not. They could leave it down, and the step count could, be a certain number, but it actually was twice that because for half the day they were gone and they didn't have their phone on them. So, while these data counters and trackers are good, unless you're physically wearing it or using it, it's not always the best with this passive information. I think it would also be interesting to delineate by fracture type, pelvic fracture versus ankle fracture or weight bearing status after surgery. Those type of things make a difference in terms of recovery. So this study is helpful, but I don't think it gives enough granular data to provide in-depth counseling per se.
Yeah, I mean, you mentioned Kaiser Soze, and I really hope that this is not a Kaiser Soze paper. The byline for Kaiser Soze in the movie The Usual Suspects is the greatest trick the devil ever pulled was convincing the world he didn't exist. And the byline for our Kaiser Soze in the orthopedic space would be the greatest trick the devil ever pulled was convincing you didn't need to study this paper for your OITE or ABOS Part 1 or WBLA, maintenance of certification, whatever it may be. But for those who are picking up their test writing examination pens and are poised to pen some type of test question about this, I encourage you listeners, put it down, drop that pen. They are clearly very upfront about this is proof of concept data. And the intent is not to actually evaluate the number of steps or anything like that. The intent is to prove the concept of the value of the utility in the lower extremity fracture population. So don't take data that comes out of this that they may be reporting and be like, oh, yes, so now this is applicable or translational or translatable or generalizable, because it clearly isn't. For all the reasons that you said. One, they're not even, that's not really the intent even around this. And they're going to be limited in clinical variation. They're going to be limited in representation, and it's not going to be universal. You'd need a much larger sample for some of the things that you're postulating. Interestingly enough, and as an aside, the secret to publishing research in JBJS can be learned by watching The Usual Suspects in its entirety and then listening to track 5, Assassination Day, on the 1996 Ghostface album, Iron Man. So for those who are listening, you want to learn about what the secret is to publishing in JBJS. I just gave you the answers. Hit me back. Don't at me about it. But anyhow, yeah. So I mean, at the end of the day, let's also keep in mind that this type of diagnostic research, for real validity, you need 3 things. In this case, everyone receives the correct battery of tests, which could be argued, but the other 2 things are missing, which is adequate representation across the universe of possible permutations of the condition of interest, and then comparison to an independent gold standard. And those parts I don't think have really been effectuated in this in a robust way. They've been touched on tangentially in some ways, but clearly, again, it's a proof of concept study. So you can't even argue it's not there or it is there, because it's not even supposed to be there. It's a proof of concept study. So by definition, it's not going to have those trappings of a robust diagnostic investigation that would provide definitive evidence on some front. And were you to really want to do that, I think you'd have to be a lot more narrow. It would have to just be like tibial plateau fractures or ankle fractures or, peripelvic trauma or something like that. So you don't get this like wide heterogeneity.
Yep. Too broad for lower extremity.
And I mean, you've watched Usual Suspects and listened to Assassination Day, so you know that the secrets to publishing in JBJS are there as well. That's how you got to be the executive editor. All right, let's move into the Your Case is on Hold featurette. Risk of venous thromboembolism in pediatric patients with surgically treated lower extremity fractures, a propensity matched cohort study by Matal and colleagues with a comment, infographic, and 30 days free for our OTB JBJS enthusiasts. You hit the perfecta once again today. This is another one that I feel like, my agent was probably so focused on the first paper, they forgot to mention that they didn't want me to cover this one either. So bad on them. But as I was looking at this, I was like, this is another great study to talk about artifacts within statistical approaches, propensity score matching, a lot of rich stuff in a substrate here for us to deploy and discuss. So this is a study using TriNetX, the TriNetX research network. I'm seeing a lot more TriNetX papers using this one. It was like we already covered a NISQUIP, and like the heyday of NISQUIP was probably 8 to 10 years ago, actually. And then after NISQUIP, it was Pearl Diver. And then it was like the Pearl Diver Mariner database. And then you got some mixing in of Optum and Market Scan. And now we're seeing a lot of TriNetX. That's like the next. I wrote an editorial for the Journal of Orthopedic Trauma where I likened these types of databases to like oil fields, like drilling for oil, and you're gonna like run it, like the mine is gonna get tapped at some point, like it's gonna run out. And when you run out, you got to find your new like data set that hasn't been, so that you can go ask that one the question. So that's what like TriNetX is coming into its prime at this point. So this was a study where the authors really wanted to look at the risk of VTE. This is the special VTE issue of JBJS in pediatric patients with surgically treated lower extremity fractures on the basis of age and lower extremity fracture location. So the way they went about this is that they developed a propensity score, and the propensity score took into account the exposure, which is the age group, and the outcome of interest, VTE. And then they say pinpointing, which is kind of a vague term. It's not methodologically precise, certainly, but pinpointing sex, diabetes mellitus, tobacco use, and body mass index as factors. So this was the initial aggression analysis that they looked at. And then they were matching individuals with similar propensity scores to balance covariates and minimize confounding per them. So, I mean, the first thing that came to mind is that like they have groups here of children, adolescents, and adults, right? And one of the factors that they're considering is tobacco use in children. I mean, like I'm not saying that it doesn't happen, of course, but if it does happen, oftentimes it's probably unlikely to be reported to the doctor, such that it's going to end up in the TriNetX data set. They don't report the caliper, or well, they do report the caliper, rather. I'm sorry. They do report the caliper, but it's utilizing a greedy nearest neighbor algorithm with a caliper of 0.1. So a fairly narrow caliper, right? So it's just like when you're doing a propensity score match, you're basically trying to get these groups to look like each other, right? So these, the independent logic, the final end state of this logic is that the children who are being matched to adults are being matched because they kind of look like adults, right? And that's just kind of like when I say it out loud, you're like, wow, that's bizarre. Like children who look like adults.
Oh no. I've taken care of these like 230-pound 16-year-olds, right? That had a cast on when I was a resident. And they go, they are bigger than me.
Yeah, and maybe it is like that, or maybe it's just they look like the adults based on their risk factors for VTE. Okay, so this is a very challenging approach because basically what you're doing is you're wanting to look at children versus adolescents versus adults, which I think is somewhat problematic anyway, because children are not adults. That's like the first like commandment of pediatrics, right? Children are not
Little
little,
adults. Yeah.
right? They're not little adults. And also it's like the statistical approach is basically finding children who have characteristics that are more adult like. It's not your average kid. It's a kid that is going to be looking at least within, point one on the scale of this caliper. When you squint your eyes, they're kind of more to like an adult, or you're finding adults who are more like children, but I don't think that that's the case with these characteristics that they considered: BMI, tobacco use, diabetes, and that may also be just sort of developing this composite for the VTE risk, which may explain some of the findings later that they're wanting to point out. So they say they use the TriNet X Live platform for data compilation. I'm not sure exactly what that is. Typically, when it's sort of these like, Pearl Diver has it. You have to like go through their website to like basically plug things in. You don't actually have the data. And that's always like a red flag for somebody who's versed in methodology, because you can't do your independent validations and logic checks and drop people with characteristics that just sort of don't make sense. You can't really check for coding errors and inconsistencies in the data. There's no data cleanse capacity. So that's always something of a concern. What's also a concern is they matched all the children. They had 84,207 children in this total cohort of 634,880. And it looks like they found matches for all of them, which usually indicates that your match is too permissive. If from a, like, if you can find matches for everybody, it's like make it narrow the caliper, make it more restrictive. But in this case, it's also kind of like, to do that, then you'd be finding kids who look even more like adults. So I don't know if that was the right approach or not. I question whether the propensity score match is really the right way to go about this, truthfully, because I'm not sure how appropriate the using reference for children versus adults. We talked about the Donnie Brasco paradigm, where you tell like a patient who's an adult, like, oh, your hip fracture. If you had a different kind of hip fracture, your outcomes would be like this. Like, and they're like, I don't care about some other fracture I don't have. I want to know about my fracture, right? So in this case, it's sort of like when you're talking about treating kids, you have to talk about treating kids, not about comparing kids to adults, because you don't treat the kid based on the fact that they're not an adult, or their risk as their risk relative to other adults is that doesn't factor into the decision. So, the study ultimately showed, and something that they're pointing out, that they're emphasizing, higher incidences of VTE in children and adolescents than previously reported for the general pediatric population. Well, why might that be, Aunt Tony? I'll tell you why it is. It's an effect of their match. They are propensity score matching based on characteristics or drivers that is going to make their group at least somewhat more similar to the adults that they're matching with. And adults, we know, have just at baseline a higher risk of VTE. So these kids are going to have a higher risk of VTE, even if it's not to the same level or the same degree. So I'm left with many of the same questions that I had relative to the previous VTE study. So their conclusions are: VTE is a rare complication in the general pediatric population. Limited research and a reliance on adult guidelines for pediatric specific management and prophylaxis protocols persist. Our findings underscore the need for a prospective multi-center study with uniform screening of patients at increased risk for VTE, particularly adolescents with pelvic or femoral fractures. So what about those conclusions told us something that we didn't sort of maybe know if you're well versed in the literature or read the introduction? There's
Problem, not a much.
Yeah, at the end of the day, I'm like, what did this tell us about that VTE is rare in kids? It's a lower rate in kids than in adults, and maybe in adolescents too. So it's an age-related phenomenon. When you're matching on risk factors for VTE, you can sort of narrow the gap, but then you'll have a higher rate of VTE in your pediatric in your compressed, condensed, truncated pediatric population than in the general population. So that's not a surprising finding. And some of the things that they're comparing to, some of the studies that they're comparing to, they go through this sort of catalog here. Sandoval has DVT incidence of 9.7 per 10,000 over a 14-year period at a single hospital. So, I mean, single hospital data is going to be limited anyway. And then an overall PE incidence of 0.1% among children and 0.4 among adolescents, while BIS and colleagues reported a lower incidence of 5.7 per 10,000 over 8 years. Again, single tertiary care hospital. So single hospital data, you can't really that's an apples to oranges, or not even, that's like pizza to fruits comparison when you're talking about a data set that's TriNet X that's collected from centers across time and across locations, and you're comparing those findings to single center findings. It's not a fair comparison, and it's not an informative comparison.
I will say that's always a very comprehensive analysis. The only thing I can say is the first author is a UT Southwestern student. So using
So you're responsible for this, ultimately, is what I'm hearing.
I'm not
That you
I'm not
fundamentally, at the end of the day, Tony, executive editor, is the person that's holding the bag on this
I'm
one.
not the senior author. It is from WashU. So the senior author is from a different institution, which that's where the databases are nice. They can look across different things. But you're right. Adolescents, kids, it's a very different thing. It's been a while since I've been in pediatric orthopedics. But do these patients typically get anticoagulation? Do you know of during these?
Well, I mean, yeah, that's the other thing, is that there are all sorts of indications for they had no way of unpacking what the perioperative treatment, in terms of if it was indicated, if it was used based on these other characteristics among any of the cohort.
Right. Makes sense. Yeah.
All right, so let's get into the honorable mentions. We have pelvic obliquity, possible risk factor for curve progression after lumbosacral hemivertebrae resection with short segmental fusion by Zhang. This study included 58 patients with congenital scoliosis who underwent one-stage posterior hemivertebral resection with short segmental fusion. They're looking at SRS-22R questionnaire preoperatively, 3 months post-op, and at last follow-up. So this is a retrospective, basically a retrospective of the author's clinical experience with these treatments. And they found preoperative pelvic obliquity was an independent risk factor for curve progression, which means that preoperative measures should be taken to ensure that this is minimized in order to effectively prevent curve progression. Then we have adolescents with osteochondritis dissecans of the femoral condyle present with high rates of corresponding coronal malalignment by Clark and colleagues. This is from Scottish Rite. So this is also the UT Southwestern special issue of JBJS. This study examined 187 knees, 156 patients, and prospectively collected clinical, demographic, radiographic data. Standard standing alignment measurements were evaluated for this institutional cohort. And they found that nearly half of the knees in scalarly immature patients may be in coronal malalignment and candidates for guided growth. Consideration should be given to addressing malalignment found during evaluations because of the adverse impact that may have on outcomes. And then we have the factors that affect operating room start times for pediatric femoral shaft fractures. This is from Boston Children's, and this is by Schwab and colleagues, and is permanently free. So this was a retrospective review of 216 pediatric patients with femoral shaft fracture admitted to the ED between 2021 and 2023. They ran a multivariable model and found ED admission time, race, method of transfer, comorbidities, and procedure type were associated with operating room start time for pediatric femoral fractures. And obviously, a longer time to start disproportionately led to longer hospital stay, because essentially those are collinear measures. I hope you enjoyed this foray into methodology, Kaiser Soze, secrets to publishing, and all the other aspects that we touched on in this special UT Southwestern VTE and pediatrics. I mean, there's so many intersections on this front Can't get enough of it. I'm sure you can't get enough of it. Tell your friends, like, subscribe, share the podcast. You can get it on Casto, Stitcher, jbjs.org, which we already covered, Apple, Spotify, wherever you get your podcasts. If you like what you heard, make sure you come back in 2 weeks to hear Dr. Chen leading us on the articles that she has now selected for publication in JBJS. If you didn't like what you heard, don't ask me. I don't pick the articles. Dr. Chen is now in charge of what gets published in the journal. So be sure to send her all the mail and all the critiques. We're about out of time. Hopefully we'll do better next time. And we look forward to seeing you back in 2 weeks.